Hello everyone, I hope you all are doing fine. Today I am going to start with topic cysts and tumors. The most common odontogenic cyst is the periapical cyst. With an inflammatory etiology, the most common developmental odontogenic cyst is the dentigerous cyst. The nasopalatine duct cyst is the most common non-odontogenic cyst in the maxilla. Radiolucences greater than 6 mm in the area of incisive foramen are considered pathologic. Most common odontogenic tumor is odontoma. The second most common odontogenic tumor is ameloblastoma. Pseudocyst. Idiopathic bone cavity. Traumatic bone cyst is an incorrect term as there is no cyst lining, aneurysmal bone cyst, and stiffened bone cyst. Radiographic appearance. Unicystic radiolucency lesion, example radicular cyst, dentigenous cyst. Multilocular radiolucent lesion, example ameloblastoma, OKC. Mixed radiolucent radiopaque lesion is of odontoma. Lesions seen as multilocular radiolucences are odontogenic keratosis. Lesions seen as multilocular radiolucences are OKC, ameloblastoma. Enucleation is defined as removal of the soft tissue lining and cyst or tumor produced by the lesion from its bony cavity. It can be done through the extraction socket if cyst is smaller. If larger cyst, first incision is given, then flap is raised, then create a bone window, then cyst enucleation and closure. Steps of enucleation: curettage. Using a curette to scrape or scoop the soft tissue and some hard tissue produced by the lesion from its bony cavity. Next one is peripheral ostectomy. Removal of a layer of hard tissue from a bony cavity, usually with a rotatory handpiece, and burr after removal of all visible soft tissue. Part 1, which is marsupialization. In this step, it is the one-step procedure. The cystic cavity is converted into pouch by creating a bony window over the cyst and suturing the cut edge of the cyst lining to the surrounding oral mucosa. Part 2 is enucleation of the lesion followed by primary closure. Waldron's method, two-stage procedure, marsupialization followed by enucleation. Decompression is distinguished from marsupialization by making a smaller window in the lesion and securing a tube for daily irrigation. Resection is marginal resection, resection without continuity defect, segmental resection with continuity defect, and hemimandibular. Enucleation is in periapical cyst, dentigerous cyst, adenomatoid cyst, odontogenic tumor, odontoma. Curettage in non-aggressive giant cell granuloma, aneurysmal bone cyst. Resection in solid or multicystic ameloblastoma, mural unicystic ameloblastoma, odontogenic myxoma, odontosarcoma. Pathogenesis of radicular cyst involves cyst initiation, cyst formation, and cyst enlargement. Radicular cyst is treated by enucleation. The involved non-vital teeth is Salvageable root canal treatment has to be done. Cyst enucleation is followed by apicectomy and root and filling. If non salvageable, extraction of the involved teeth is done. Reasons for recurrence or persistence of odontogenic cyst. OKC are difficult to enucleate as epithelial lining is thin. Daughter or satellite cysts persist within the bone beyond the perceived margin. Epithelial remnants from the dentinal lamina may residue within the attached alveolar mucosa overlying the primary lesion. Abnormal function of the tumor suppressor gene (PTCH) occur in both nevoid basal cell carcinoma syndrome, which is characterized by multiple OKCs. OKC expand anteroposteriorly while ameloblastoma expand buccolingually. Treatment of OKC: decompression or marsupialization with or without layer cystectomy, enucleation combined with excision of the overlying mucosa, and Carney solution application to the bony defect, and enucleation combined with liquid nitrogen application to the osseous cavity. Block resection is rarely done. After enucleation, topical application of 5-FU efficiency treat OKC. Carney solution is 3 ml of chloroform, 6 ml of absolute ethanol, 1 ml of glacial acetic acid, 1 gram of ferric chloride. Carney solution is a tissue fixative which penetrates bone to the depth of 1.54 mm. Modified Carney solution is without chloroform. A solid ameloblastoma of the mandible is resected with for 1 cm to 1.5 cm linear margins and one uninvolved anatomic barrier. Example: supraperiosteal dissection in the setting of cortical plate perforation. Unicystic ameloblastoma has 3 histological patterns: intraluminal, luminal, mural. Intraluminal and luminal can be enucleate. For mural, resection has to be done. Fibrous dysplasia, recontouring if needed. Periapical cemental dysplasia, no treatment is needed. Cementoblastoma, extraction of the tooth along with the lesion. Adjunctive chemotherapy options of the central giant cell granuloma include intranasal or subcutaneous calcitonin and glucocorticoids, and therapy with interferon alpha is needed. Surgically, the ABC appearance as blood-soaked sponge, whereas surgical exploration into the idiopathic bone cavity reveals either an empty cavity or cavity filled with fluid.